A little bit about me. I lived in the Dallas-Fort Worth area for 17 years. I taught at UTA for 17 years, moved away for 13, and back now. I'm serving as a nurse scientist for Texas Health Resources, and I'm the incoming president-elect of ANAXL. Been in simulation since about 2004 and was really sucked into simulation by Dr. Mindy Anderson at UTA. So I always thank her for that opportunity. So I'm just going to go ahead with my talk. I think that's plenty of intro for me. So we're going to compare and contrast, kind of like you were before, what was happening and was considered possible in simulation before COVID, as COVID hit, and now. And we're going to be considering new possibilities with these unexpected simulation opportunities. So you might think this is an early version of a COVID mask, but it really isn't. There's nothing new under the sun. And this is really a mask that was invented as a face shield for snow in the Canadian winters around 1926. Before COVID, things were moving along pretty well. Simulation was really being adopted and used by more and more schools. We loved it. We thought it was great. We have standards, big conferences. There's a lot going on. And in my world, I really thought that the next big thing was going to be virtual reality. And what we see here is I was lucky enough to be funded to help build a game for sterile urinary catheterization when I was at Boise State University. And we got a lot of mileage out of it. We were one of the first groups who really used and could see your hands in front of your face and interact with a game using your hands as opposed to controllers. So we were using leap motion before anybody really was adopting that for this modality in any way. It was lovely. We had a great time. The problem is the headsets are big and clunky, as you can see. And so I really thought that was going to be big. And then we had a friend who is at Centennial College, Ryerson University, who had developed another kind of virtual healthcare experience. It's very cost effective. It uses basically PowerPoint and short videos built into a branching logic that gives you an opportunity to experience all kinds of things for nursing healthcare, and it helps teach. I have included her link at the end of this presentation so that you can all go there and see it. She is now funded by the Canadian government, and we'll keep building things. As you can contact her and let her know what you think you'd like to see next, and she might do that. It's very well done. And the other big thing that was really being adopted like crazy were escape rooms. I don't know if you've ever had the opportunity to play in an escape room, but I finally got to do it with some buddies at the Center for Medical Simulation for a course. And it was awesome. And it was online and virtual. It was a blast. I've also heard of nursing faculty going and trying to participate in an escape room, and their brains were all so similar that they couldn't get out of the room. So you want to consider that. If you go to something like an escape room, you want to have people with different, diverse ways of thinking. And I don't know if I would say that it's necessary to have people who are the different ways of knowing or the different skill sets, but you want people who think differently. You want some left brain and some right brain people to be able to be successful. And this became so much the rage that there are all kinds of articles out about this now, and there are already almost some basic standards being published. And I will say that Dr. Mindy Anderson, my old compatriot, and one of a few of her buddies have published basically guidelines in simulation and gaming. I can't get my hands on that article yet, but you might want to look for it. So this is just an example of some things. And then look at this from their website, at Mindy's website from the University of South Florida now. They have a whole pedagogy listed here for how to use escape rooms. So take a look at that. If you're interested in this modality, it seems to work very well for students. The other thing that's coming and is starting to really create a problem is that everything's been called virtual. And remember, virtual's been around a while now, and the vSIMs were sold as virtual reality because we didn't really know what we were talking about or saying then. So virtual simulations are now really becoming big, but before COVID, they were being used and around, and lots of publications, along with other three-dimensional types of games, and other great ideas were happening. So this sounds a little bit disjointing, but I'm listening to myself in the background and I'm losing my train of thought, so please forgive me. One of the great other new ideas pre-COVID, which has really kept them going during the pandemic, was this basically oven that's on the back of an electric bike so that you can get hot pizzas delivered even in the cities. And they had started with cars for Domino's, but this really took off because you're able to then set the pizza down hot and somebody can pick it up right then and run away in the big city. So talk about timing and great things happening. Along with all of this work that's been done pre-COVID, there were lots of things that became dogma, like you must debrief after everything. And we were always thinking that there was a certain kind of debriefing that must be done. And that is really not true. But once we get standards published and we think we know what we're doing, it becomes settled science, and this is what we're going to do. And then sometimes we're very surprised. As long as centuries, as short as weeks, things change. COVID came along. And for medicine, this is the abstract for an article, and I'm sure that you know that if you go to the PubMed website, anything that has got anything to do with the pandemic that might provide help for somebody along the way around the world is now open access and free. It's amazing what is out there. You can spend days looking through those right now. But this is what happened for most people who were out of medical school. In early 2020, the pandemic hit, everything shut down, and people who were interns and residents were expected now to start functioning immediately as physicians and nurses, as physicians. Schools closed around the world. 290 million students were let out, including college students, into the world with or without any plan for further education. This became quite a big deal in the United States because state by state, boards of nursing had to decide what they were going to do with their students who were trying to finish school. Remember that school closed down around the end of March. Most people had done all of their coursework, but needed to finish up their long-term clinical, their capstone projects and capstone experiences. The Board of Nursing was not acting here in Texas. Governor Abbott took action to expand the nursing workforce by saying that it was okay that we could use simulation to finish up whatever was needed for those people who were graduating. This included, because remember, centers were closed down, we also then were using screen-based simulation. So some states like California could not adapt quickly and were told to hold all May graduates back a year. Other states started moving forward with adopting sim to finish clinical hours in whatever fashion they could possibly find. So California only in the last month or two has moved on this and has allowed things to move forward to allow the May graduates to move forward. So it has been a crazy, crazy spring semester. Along with this, a lot of innovation happened. And we heard some of that in our pre-talk before, in our visiting time before we started this presentation. So let's look at some of the things that have happened. These are really interesting pictures to me. The one on the left is using artificial intelligence to read splatter that comes from droplet and aerosolizing things when you're doing intubations. So they're really studying how far are these germs spreading, these viruses spreading when you are doing things like intubations, etc. The one on the right is the use of a drone called Digital Aeroless, and it is testing disinfecting with UVC lights with its industrial drones moving around the room after a COVID patient has been in the room to disinfect the room entirely. Is that not the coolest thing? I just love it. Along with all of the different ways we were doing SIM, people started realizing, especially if you look at the PubMed website, that people are calling distance simulation, remote simulation, telesimulation, virtual simulation, a lot of different things. And what we're finding too is that when they describe what they're doing, you sometimes can't tell what they did. It is very, very confusing. So it is a wild time. There is no standardization of what this different kinds of simulation is being called. Here's another example. This is just a slide I found, and they're calling it remote, distance, tele, virtual also. And what is it we're doing? Here's another example of what I'm talking about. We're talking about virtual simulation, and in this case, all they're doing is talking about the use of vSIM. So when we say virtual SIM, we have to be very clear and try to understand what we're talking about. Another thing that was being used, probably by some of you in this audience, was robotic SIM, or we call it doctor on a stick, nurse on a stick. And it really is an iPad on a rolling something that moves from room to room. We were starting to use this at Texas Health Resources to do virtual visits by the psychiatrist for our hospital because they didn't have one on site at the moment. So we had the real ethical dilemma talking about how does a schizophrenic patient who's going to have a virtual visit with a doctor on a stick react? How does that work? Is this really a safe thing to do for somebody who already may have a questionable touch with reality? So as we read these articles that were coming in, and I review for a lot of journals, and we're talking about doc on a stick or remote simulation or telehealth like this, we thought, oh, isn't that cute? Isn't that clever? Really neat. These people are really on the cutting edge. But then as COVID hit, we started having a lot of doctor visits now paid for and reimbursed by Medicare, Medicaid, et cetera, for these kinds of visits. And insurance companies started reimbursing for this because people don't have to go to the doctor's office. So this is great. But this is something that we thought, this is really novel. This is, will catch on eventually, never dreaming it was now going to have to be another thing that we're going to need to teach our nurses and physicians before they get out of school, because a lot of healthcare is going to be delivered this way. So all kinds of things started happening pretty quickly. There's a group out of the Inspire group that really started looking at this and held a healthcare distance simulation summit and really talking about the problem of nomenclature. And this man at the bottom right here is Dr. Todd Chang. I have given you the link to this little video at the end of this presentation so that you can watch this. But he was right on top of it immediately when you start talking about how do you describe what we're doing in simulation now. And he came up with the use of pictographs for telling people what's going on when you're trying to describe things. And it saves us so many words. It's an amazing idea. So we see that we've got a mannequin, operator, the facilitator, the learner. Simple so far. Here we can see this pictograph shows we're all in the same room. It's not often that the operator would be in the same room, but sometimes it's true. Here's where the facilitator is remote. That's what this, you can't, if you can see my mouse above my moving around here, that's what I'm showing you right up here. And we've got the operator, the learners in the room with a mannequin, a standardized patient, something. Here we have remote operated sim. The operator's far away and the facilitator, the learners are in the room with the mannequin. We also often are looking at things like this. The facilitator is now someplace else. There might be a learner in the room with the mannequin or a standardized patient, and another learner can be far away, and the operator can be far away. So there are all kinds of permutations that can be occurring. And it's interesting, they are doing something similar to this at Johns Hopkins now, and I have a slide that will show you more about that right now, but remember this slide. The other thing is that sometimes everybody's remote and the standardized patient or the mannequin is also remote. So you see how complicated it can get, but everybody's doing this at this time. The other thing that's happening is that there might be a delay. There might be a learner working with a mannequin or a standardized patient online. There's a time delay, and then another learner might do something, and the facilitator then might debrief everybody. Craziness. At Johns Hopkins, they're running scenarios right now that if you are old enough to remember Hollywood Squares, it kind of looks like this. Everybody's there in Zoom. They have two patients who are standardized patients. They have a facilitator. They have two students or a student, and they have maybe a mannequin or two. And the student takes report on the patients, the four patients, the two standardized patients, the two mannequins, and they start processing out loud what they would do, who they would go see first, what their priorities would be, and then the facilitator is on the side there to help guide if needed, to ask questions along the way. They could almost be doing a rapid cycle debriefing as they're moving along. So I have seen this in action. It was amazing. The student almost had smoke coming out of his ears. He was working so hard and thinking so hard, but it was awesome to watch. So what are these different kinds of things called, really? So you've taken a look at this, you know, and I'm wondering what you all are calling things. And when I get back to my thought about the promise of virtual reality, I thought it was going to be great. It should be great. It solves a lot of the problems that we have right now during COVID. If everybody was at home with their headsets on and well-designed programs, a lot of things could be done. I don't know how many of you have had a headset on for VR. It is totally immersive. And the terms that go with this are presence and immersion. Even when you can't touch things, it's got little patches over your ears so that you're blocking out any sounds that are not provided outside of the program itself. And you are totally immersed. When you look around 360 degrees, you are someplace else. It is amazing, fabulous for learning. And I thought it was really going to be the answer. But sometimes great ideas don't work out. And here, for example, on the left, is an idea that somebody had as a way to get over a hangover. You put your hands in a bath of water, and a gentle electric current runs through you. Probably not the best idea. And on the right, here's an idea for protecting your cigarettes from the rain. So I really thought VR was going to be the answer. And there's a lot of stuff published about why VR really hasn't taken off. And I don't know if you know the history of VR, but when Mark Zuckerberg saw Oculus Rift in about 2014, I believe it was, he bought the company for $2 billion and then locked up Oculus Rift for a while. And that really hurt us because as we were developing our game in Boise and we're trying to commercialize it, nobody could get their hands on other Oculus Rifts to be able to try things out. So that was one problem. It was locked up, and I think that he was really working on trying to commercialize this in some way, but right now the headsets were so big and clunky. And then during the pandemic, I don't know if you've tried to order a virtual reality, if your significant other has been so bored with other computer games that they're trying to order one of the headsets that go with this now, this idea, but they're 6 months back ordered. So you have to wait a long time. And the idea of using it for education is great, except that you can't get enough headsets and there are not enough games built. The next big thing that happened, and this people are really paying attention to this now because October just went by. And Mark Zuckerberg for Oculus decided that anybody who's going to use anything with Oculus has to have a Facebook account. The problem is with Facebook and Oculus, they can track every single move you make, every single thing you do. And there used to be ads that went with everything. So they're going to know everything about you because you have to have a Facebook account. And when you're using some of these games, it literally tracks where your eyes are moving around the room, where your hands are moving, and they can tell a whole lot about you that you may or may not want to know, or that we may or may not want anybody to know about our students. As a researcher, I might think it's great, but as a student who's trying to learn something, and I maybe am a little slower than somebody else, this opens up a lot of ethical questions for many reasons on many levels. So when we look at the adoption of innovation, and it, again, in my world, I really thought that VR would be huge, maybe not so much. I think that virtual simulations or telesimulation is going to be huge, and I look forward to talking with you all about that and what you're doing. But The idea of having us all separated is going to probably go on for a while, longer than we thought. So when we're trying to prepare for a new normal, I don't know how sick you are of attending telesimulation conferences or teleconferences, but I think we're all gaining weight and getting cellulite on our butts from sitting around doing these kinds of things. However, this is the way it's going to be for a while. So the new normal, who knew? Having said that, many cool things are happening, and the adoption of digital tools during the pandemic is going to transform healthcare permanently. When we've been asked, how long do you think you'll keep doing this? A lot of us think because we were forced into adopting simulation or online learning that everything will go back to the way it was. When it is cost effective and universities and hospitals are having huge budget problems for multiple reasons, I don't know that a lot of us who think things will go back to the way they were is that that's really going to happen. And so I think we need to be what do I want to say? Continue with flexibility, continue with an open mind. If I wasn't an early adopter, I would really try to make myself become more of an early adopter these days, because something that you see may become that next big thing that you're going to be teaching with, or that we're going to be using orienting nurses in the hospital for quite a while to come. The things that we need to ask ourselves are really, what can't you learn or teach in the online environment? And it's very interesting. By accident, I found this Macy report from 2018 that kind of addressed this question. And the things that they came up with were professional identity. What does being a respiratory therapist, what does being a nurse, what does being a physician mean, really? How do you learn and act like what that is? Learner to patient communication. And the recent research that I'm working on shows that we're not really doing a good job with that, probably for medicine or nursing, either one. And organizational culture and practices. How do you learn? You really can't simulate it when you're doing an online environment. Um, which nurse is going to help you? Which physician can you ask for things and be pretty sure you're going to be able to get it? Um, it's a very interesting thought and problem. So I'm curious about what you think. What can't you learn in an online environment? And what their conclusion was you can learn almost everything if the learning is designed well. And I'm not sure I believe that. The other thing that I think it's of interest for the nurses in the audience to know is that the National Council of State Boards of Nursing is very concerned about the class that just graduated this last May and what's happening for students right now. I was a consultant on the first National Council of State Boards of Nursing National Simulation Study, and they swore at the end of that, literally fists in the air, saying, we will never do another simulation study as long as we live. And then COVID hit. And so they're running a study right now, and this one's called the National NCSBN National Pre-Licensure RN Study, Assessing the Impact of COVID on Nursing Education. And they're looking at the forced screen-based simulation use and VR, except that most hospitals really were not using VR yet. And they had to come up with what are the outcomes they're going to measure and how are they going to do this? So what they did is they adopted several of the measures that were used in that first National Council study. Somewhere between 95 and 200 schools were invited to participate. They are comparing the last academic year pre-COVID, which would be what, 2020 completing. So that May and that academic year of 2020, 1920, and they're looking at uh, all the scores on HESI, and they used HESI because so many schools were using it. I lied. Uh, ATI. So they're using ATI outcomes at the end of every course and at the end of the program, and they're looking at those graduates that came out then compared to the ones that came out in 2020 this May. And they're looking at what those scores were and what people who are hiring them are saying in the first 6 months, 3 months, 6 weeks, 6 weeks it is, of since graduation as they start working in the real work environment. So they're trying to get a bead on what has happened, and that work will inform another enormous National Council, State Boards of Nursing, National SIM Study 2.0. And that will be planned over this next year after the results are in May for this particular study that's going on right now. So I've looked at the website. There's not anything up on the website right now, but I would start looking for it probably in, January, February, to see if they're going to be talking about this, if they've updated the website and they've got this particular study that you have on the screen right now, who's participating and what are they finding thus far. They said they didn't want to do this, but with the advent of so many changes and so much adoption of screen-based SIM, they feel like they must do things and evaluate what's going on. If I was a researcher, and I am, I would think about all the things I've already talked about, and I would look at the research questions that are posed in each of the articles that are in this 2011 monograph from the Society for Simulation in Healthcare. Most of them, I would have to say, have not really been answered even yet. And this is 9 years old. But overlaying those very thoughtful questions onto these new modalities makes perfect sense to me. So you notice that this is actually my copy. It's kind of dog-eared. It looks like it's well worn because I could almost say I sleep with it under my pillow, but not really. But if you haven't seen this, you want to read it. Having said all of these different things, the important thing to know, and this is a great little book about this, is that our culture loves innovation, sometimes to the detriment of things that we should be using that work really well and are cost effective. So just because you can do something, that doesn't mean you should. So I highly recommend this book and the thought of not throwing baby out with the bathwater as we move forward in whatever new normal is coming. So I would think long and hard about some of the things that we're doing, and some of them may be worth keeping, and some may not. I will say that I'm working with Kim Layton and a team on using the CLEX 2.0, which is a tool that she designed to help measure learning students' perceptions of learning outcomes between the traditional clinical environment, simulation, and now the 2.0 has got screen-based simulation attached to it. And our data is fairly devastating for screen-based sim. Compared to traditional clinical face-to-face in the hospital or the clinic or wherever we're going, screen-based does not hold up very well at all, like not at all. And that could be because the population that we sampled were the people who were graduating it through this very chaotic time from March basically till May, June. And that could be, our findings could be a reflection of the being thrown into this screen-based environment uh, by faculty who are also thrown into screen-based environments. So that those articles are very interesting, but this is why I hesitate to really fall in love with screen-based sim. A shameless plug as I'm getting ready to finish my talk. And if you're looking for a master's in simulation operations, the Massachusetts General Hospital Institute of Health Professions is here for you with the first master's in simulation operations available and a PhD in health studies, basically with a focus in simulation, if you're interested in that sort of thing. So I teach in that program, would love to talk with you about it. And so I am wondering about your innovations that you have experienced during COVID and what your thoughts are about writing them up as just a this is how we did it article or actually doing research on it. And I'd love to open the floor for discussion now. Having said that, I cannot see my screen. I cannot see anybody or anything. What I'm going to do is finish up my last two slides, and then I will take down my screen so I can see everybody. So here's my contact information if you want to chat with me. And here are the references that I used and things that I think are really, really good with COVID resources for you. And the wonderful virtual clinical experiences, which are free for use from Ryerson, Canada, they're available for you. So I'm going to close out and I'm going to stop sharing my screen. And I look forward to chatting with you. Okay, so I see a question here. Susie, do you think learners' cognitive load impedes learning in VR? I will say I think the cognitive load is less in VR because if you can use your actual hands in front of your face and it looks like you're in a clinical environment, the cognitive load will be less. But we don't know. We need some research. Can I put my contact info? Okay. Will we have access? You will have access to this presentation after the webinar. They theoretically they filmed it and I will give you my slides and they have my slides, I think. No, they don't have my slides. I will make sure they have my slides. Okay, from Alita Martin, I have an example I would like to share.
Oh, sorry. It's like, how do I unmute myself? Can you hear me?
We can hear you.
Okay, one thing that we did, we originally had seen that Zoom virtual simulation thing that the Chicago University had put out, and we're trying to do that, but it was via Zoom, and we were not able to use Zoom. We had to go to WebEx. So in order, our first one didn't work so great, but the second one we changed is we put a webcam and actually literally strapped it to one of the simulation educators, and she had a mannequin in front of her, and so then you could see as she would see as the nurse who was being directed on what they needed to do. If they wanted to have her start a pump at XYZ drip, then she had pumps there that from the webcam that was strapped to her chest, they would see through her eyes, so to speak. And that really made a big difference.
I love it. I love it. I've heard of somebody too saying that what they're doing is they have the faculty in the lab, and this is for teaching skills, and they have the students out in the virtual world, talking the lab person through the skill. And the idea is if you can teach somebody else how to do it, then you probably know how to do it. And that is a way to cope. So if that's something. Okay, and I see from Sarah, I fully agree with you that it has been helping out so much with them not being on site like this. So Sarah's agreeing with you. Anybody else have anything they want to say? What do you think you will keep that you're doing right now?
I think that we're going to keep the virtual, we call it virtual telesim. We're going to keep the ones that are, a lot of them that are communication based, about the nurse having to call the doctor or contact the charge nurse, or we call it a communication based one, which doesn't have a lot to do with the patient per se. And we found that those are fine to be done in a virtual setting. And then we had our nursing educator that's over the residency nurse program to channel down and say what ones must be done in person, because we're going to keep it to very specific, 3 or 4 people at a time. So we're only allowing 10 people total within the lab at one time. And so that kind of made her focus on ones that she felt were really, really important that be done in person.
Great. I think a lot of people are thinking really hard about what is need to know versus nice to know as we move forward in time. Probably work that should have been done. We've been forced into it, and that's a good thing. But there's a lot of not so good thing too.
This is Karen Meadows, and I'm the Director of Simulation at the University of North Texas Health Science Center. What we're doing is we have our PA studies group that is using a screen-based simulation with their first years. And so this is the group who hasn't been able to get into the facilities very much. And this is an immersive, we're using Oxford Medical Simulation, which is, it can be used with a headset, but in order for all of those students to be able to access it, we don't have headsets for everyone to take home. So we're using the screen-based version with them. And we've had very good positive results from this, or positive comments, I guess, from the students. I couldn't speak to the outcomes because I don't have that data. But from what I'm hearing from that department is they're really liking, and they feel like that COVID forced them to try something new that they wouldn't have done before, but they may keep some components of that beyond COVID because they're having a good experience with it. We're also doing with our DO students, we're doing what we call online simulation. So there's yet another term to throw in there to your list, but it's a Zoom patient encounter so that the DO students can practice medical interviewing. And so it's not exactly telehealth, but it's similar to that. And I think some components of telehealth will definitely stick around a little bit longer post-COVID. So that's kind of our experience anyway.
Karen, I'd love to pick up what you just said there, because one of the critiques of our students from nursing faculty in the last couple of years has been, and probably for everybody, is that they look at their screen so much, they don't pick up on the nonverbal communication that so many of us give off, and our patients most certainly do. And that when they have to look at a screen this way, it's a big screen. Admittedly, it's not necessarily their phone, but they're actually probably going to get better at looking at nonverbal communication. So this could be a good outcome of having to have this happen. So it's something to consider.
Hi, this is Sarah from Houston Community College. So what we've been doing, I guess you could say, is a combination of online, tele, and virtual simulation. So we just got a little bit of the Oxford Medical Simulation to utilize. But we also had the Body Interact clinical reasoning table that we've been using virtually as well. I've been typically using that to replace some of their ATI and things of that nature to kind of boost their simulation. But we've really, I guess, been honing in on the telemedicine type of sim, the telesims, because we just recently went back on campus, but we're only allowed to have so many students, of course, on campus at any given time. So I do telesimulations either from home in my patient room that I've set up, or from the campus, like Mr. Martin said, with a GoPro camera or a camera strap where they're doing it to alliterate on kind of what Ms. Meadows and you had talked about. The communication aspect has increased, tenfold with the way that they're explaining what they're going to do to their patient, how they're going to do it, why it's important that it happens to their patient. And then in addition to that, I do nonverbal cues a lot, and the students have noticed that they're picking up on that a lot more, being able to communicate with the patient. We tell our students that we know that they know their skills because they've done their skills for the students that I have currently. And so we know that they can tell their skills to their faculty member in medical terms exactly what they're doing, but we're wanting them to hone in on being able to do that with a patient and make the patient feel comfortable and understanding of what's happening. So our students, their feedback that they've been giving us so far is that if they had any choice in what they were to do, clinical based and simulation based and skills based, they would rather get off of the virtual environments where they're clicking a mouse and dealing with predetermined speeches and predetermined things that they have to do, and get into doing it more of being with somebody where they can actually just communicate with that person. Even if they can't perform the skill, they're still telling me what to do and where to auscultate, and that for them is a greater impact than doing just a computer-based simulation. So we've been enjoying it thoroughly.
That sounds great, Sarah. I would love to see you do almost a focus group of students and talk about what is it like to use screen-based program, and what's it like to do what you're talking about where they're having to describe things to somebody else, because that work hasn't been done. And I would almost predict that that's exactly what you would find, is that they're going to like that more because it's not so pre-programmed.
Right.
There's something about your hand on a mouse moving around and trying to learn how to work that equipment that I think interrupts learning and processing.
Thank you. I will definitely do a study.
Who else has something to say? And if we don't, our time is almost up. I'm happy to end, but I don't want to leave anybody out in the cold. Hearing nothing, then I'll say thank you so much. It was great to have an opportunity to visit with you and talk about some things that are happening. And I hope that COVID vaccine works soon for all of us. Thank you very much.